Hey. So, welcome back to our live, and we are doing. I mean, none of you have been connected yet, but I think I have to start the live discussion, clinical case discussions, and we will be doing 30 questions. And wherever you are, let's get started. Even if you are not live, you can watch the stream later on. I will be making it available. So, let's just begin. We'll be doing 30 questions, all right? So the first question we have is this one right here. So, a homeless 38-year-old man. So, if you are present here, I request you to please respond in the chat, all right? We'll be just discussing to make it very clear, to make it engaging, and to make it interesting too. So, let's start from question number one. A homeless 38-year-old man has a 3-month history of decreased appetite, generalized wasting, a low-grade fever, and worsening cough productive of bloody mucopurulent sputum. He has a 3-year history of alcohol abuse, X-ray, films of the chest, so consolidation and cavitary lesions in the apices of the lungs. Which of the following is the most likely inflammatory and thus our immune response in the lung? So we have a homeless man, so living conditions are not that much better, so environment is quite like detrimental to the human health. And 38-year-old man, there is a 3-month history of decreased appetite and also generalized wasting, a low-grade fever, and worsening cough. It hints kind of tuberculosis, isn't it? What do you think? It hints tuberculosis. And also the cough is productive of bloody, that is our hemoptysis, and also mucopurulent sputum. And he has a 3-year history of alcohol abuse leads a person to alcohol abuse leads to like kind of malnourished structure of the body, that is immunocompromised state, that our body's metabolic level is not that quite well. And also the x-ray films, so consolidation and cavitary lesions in the apices of the lungs, like the apices of the lungs, so it might be a secondary cause, it might be a secondary case. So which of the following is the most likely? I'm going with tuberculosis here, and I have answer key written in a paper here, not in the slide, right? So I just wanted to make this very engaging and brainstorming, so that is why it is. And tuberculosis, so what happens in the inflammation of tuberculosis? Obviously there is granulomatous inflammation with caseating necrosis, isn't it? So where is the option? The option A is endothelial cell proliferation, vascular budding, and fibroblasts. B is epithelioid cells. Alright, so granuloma has epithelioid cells, that is sleeper cells, and sleeper like sept cells, and also multinucleated giant cells, and caseation necrosis. I'm going with option B. So since there is only me in here in the live, so I'm just clicking it. Yeah, so option B is the correct one. Now question number two. Question number two has an 82-year-old man comes to the physician for evaluation of chest pain. He lives with his daughter's family. He has numerous welts and abrasions and appears to be malnourished. He says his diet is fine. Which of the following is the most appropriate next step in patient care? 82-year-old man, there is chest pain and there are welts and abrasions. It also hints kind of abuse case, maybe physical abuse case, and also appears to be malnourished, so he is not fed well. He lives in his daughter's family, and he says his diet is fine, but I don't think it is. So what next step is the most appropriate in patient care? Confront is family about the abuse, enroll the family in family counseling, and notify social services of the potential abuse. I think it is of potential abuse, so all these options seem right, but maybe we have to notify social services of the potential abuse. Yeah, so I'm going with that, and on, I think let's just begin. Now we are solving question number 3, and in the question number 3, a 67-year-old woman has the sudden onset of dyspnea, chest pain, and dies within minutes. Stage 4 ovarian cancer was diagnosed 1 year ago, and she has been bedridden for 2 months. Which of the following is most likely to be found in autopsy? So, there is a 67-year-old woman, and she had sudden onset of dyspnea, that is difficulty in breathing, alright, and chest pain also, and dies within minutes. And she had stage 4 ovarian cancer diagnosed 1 year ago, bedridden for 2 months. She is like bedridden for 2 months, so maybe a thrombus has formed, and that thrombus is causing like sudden cardiac arrest kind of thing, and that is symptomatic to chest pain and dyspnea, obviously. So I think this is a case of thrombosis, because she has been bedridden for 2 months. Potentially there is a thrombus formation in there, so that is why it can be a case of deep venous thrombosis. I'm going through it. So let's just eliminate other options. The first one is acute myocardial infarction, but I don't think it is a case of that, because we have a history of stage 4 ovarian cancer also. And 2 is deep venous thrombosis. Let's lock this one right now. So dissecting aortic aneurysm. Dissecting aortic aneurysm, the pain is kind of sharp in the dissecting aortic aneurysm, so I don't think it is. And also renal papillary necrosis, it is very widely unrelated. And then E is ruptured belly aneurysm, so I think B is the option. Let's go through it. Yeah, B is the correct answer, so kudos to us. Madan Neupani, welcome to the live. Kudos that you have corrected the question number 3 despite you are late. Let's just continue. So we have question number 4, all right. So in question number 4, a 45-year-old man has a 6-month history of burning pain that begins in the epigastric area and ascends into the chest. So history is of burning pain, and it begins in the epigastric area. It kind of hints gastritis kind of thing, or peptic ulcer, and ascends to the chest. Episodes occur most frequently after large meals and at night. Obviously it is of maybe reflux disease kind of thing. Let's just say it. What do you say, Madan Nupani? Until now, what is it? An endoscopic examination shows moderately severe inflammation in the distal 3 cm of the esophagus. Distal 3 cm. Which of the following is the most likely cause of this condition? Okay, so endoscopic examination has severe inflammation in distal 3 cm of the esophagus, right? Let's go through the options. Option A is diffuse spasm of the esophageal musculature. I don't think it is diffuse, because the question specifically says there is distal 3 cm of esophagus involved. So number B has failure of the lower esophageal sphincter to relax after a swallow. Why does the lower esophageal sphincter need to be relaxed after a swallow? It needs to be constricted, isn't it? So it doesn't make sense. The second conjugation. And third one is Helicobacter pylori infection. It can be, but it is much more complicated case, I think so. So Helicobacter pylori infection is kind of vague. Uh, and then D is hyper secretion of gastric acid. It can happen. E is inappropriate relaxation of the lower esophageal sphincter. Okay, inappropriate relaxation of the lower esophageal sphincter. Yeah, Madan, but there are two options that say that is involved, that has involved lower esophageal sphincter, number B and number E. So what do you say? What do you think it is? Failure? Is it failure or it is inappropriate relaxation? What is it? So failure, I think it is inappropriate relaxation of the lower esophageal sphincter because it is not continuous, and also in the reflux it should be like, if it was continuously refluxing, then it should have a consequential vomiting episodes also, which is not mentioned in here. And there is distal 3 centimeter involved, just distal 3 centimeter, not the proximal 3 centimeter. So maybe it is a case of inappropriate relaxation of the lower esophageal sphincter. So here I get the question why it can't be D. D1 is hypersecretion of gastric acid. It is it can be possible, but we have to choose the best option, isn't it? Like hypersecretion of gastric acid, how can the pain, the burning pain of hypersecretion of gastric acid can ascend to the chest? Just hypersecretion cannot ascend to the chest, isn't it? We have that in the question, so it must include something that is related to esophagus. So maybe inappropriate relaxation. Okay, so I'm looking at the answer key here, and it is inappropriate relaxation. B also, it all of them are quite related to the question's answer, isn't it? So let's just go through E option right here. So jump into the next question. So question number 5 is a 45-year-old woman has an acute coronary occlusion. Alright. So acute coronary occlusion, and within seconds the ischemic region shows mitochondrial swelling and depletion of glycogen granules. Which of the following metabolic events is the most likely cause of the cellular changes? So everyone, welcome to the live. 4 of you are here. Now 3, now 2. Alright, so it's okay. But let's just solve these questions. 45-year-old woman has an acute coronary occlusion. Within seconds, the ischemic region shows mitochondrial swelling and depletion of glycogen granules. Mitochondrial swelling, so there is like lack of oxygen there, and so there is no glucose utilization, so you have to utilize the glycogen granules, and that is why there is depletion of glycogen granules. So there is not like enough oxygen supply in the coronary region. Which of the following metabolic events is the most likely cause of the cellular changes? The option A is accumulation of free fatty acids, B is ATP depletion. So since there is lack of oxygen, obviously oxygen is used for ATP depletion, so I think it is ATP depletion, but I will wait for you guys. Alright, so option C is degradation of membrane phospholipid. For mitochondrial swelling to happen, degradation of membrane phospholipid is required, but it is not necessary. Alright, because the swelling can happen due to the defect in sodium potassium pump also. and that utilizes ATP. Sodium potassium ATPase pump utilizes ATP. There is lack of oxygen, so ATP cannot be utilized in that pump. That is why there is like imbalance between sodium influx and potassium efflux kind of thing. So potassium influx and sodium efflux kind of thing. That is why there is swelling, mitochondrial swelling, and depletion of glycogen granules is due to lack of oxygen. So reserved glycogen should be used. That is why it is there. So I think option B is right. That is ATP depletion. And answer key says so too. Seems like it's only you and me discussing Madan Nupane, but it's still fun. Let's go through question number 6. So question number 6, it says a 65-year-old man dies of bronchopneumonia. It has a 6-year history of progressive loss of facial expression, tremors, rigidity, and slowing of voluntary movement. At autopsy, loss of pigmented cells is noted in the substantia nigra. Which of the following additional abnormalities is most likely to be present? So the man died of bronchopneumonia, alright? So there is 6-year history of progressive loss of facial expression. So facial muscles are not working quite well. There is tremors and rigidity. It sounds like Parkinson's disease. And slowing of voluntary movement. Yeah, it sounds like Parkinson's disease, isn't it? At autopsy, loss of pigmented cells is noted in the substantia nigra. It is Parkinson's disease. So which of the following additional abnormalities is most likely to be present? Option A is eosinophilic inclusions or Levy bodies in the neurons of substantia nigra. I think this is the answer, but let's just tap into the other options. So B is loss of neurons in the caudate nuclei. Caudate nuclei, there are no symptoms related to the caudate nuclei because caudate nuclei is kind of related to caudate nuclei and putamen. These are actually like caudate nucleus is C-shaped brain structure, and it is present in the basal ganglia, and it is kind of related to procedural learning and reward-based learning and cognitive functions like attention. So I don't think it is caudate nuclei. So option C is microglial nodules and multinucleated giant cells in the white matter. Doesn't make sense. And neurofibrillary tangles in the cortical neurons. It is typical of Alzheimer's disease, and viral inclusions in the oligodendrocytes. I don't think it is a case of inflammation. Alright. So let's go to the body, like option A, which is eosinophilic inclusions, Levy bodies in neurons of the substantia nigra. Yeah, it is a case of Parkinson's disease, and the answer key says it is right. Let's go to the question number 7 now. Okay, the question is quite long here. A 50-year-old man has a 10-year history of poorly controlled hypertension. Okay, vital signs are pulse is 96 per minute, respirations that is 16 per minute, and blood pressure that is left arm 226 by 120 mmHg. It is quite like it is maximum case, and also it is a case of hypertensive crisis kind of thing. And then right arm, it is 218 by 118 mmHg, almost equal, but there is kind of delay in between. So with the patient in the left lateral decubitus position, a late diastolic sound is heard, best with the bale at the apex, not the diaphragm, best at the bale of the apex. Like in the stethoscope we have diaphragm and bale, right? So it is heard best in the bale. So which of the following is the most likely explanation for this auscultatory finding? Aortic insufficiency? I don't think so. Late diastolic sound. What do you think, Madan Upani, if you are still here? I'm looking forward for you. Now we became three from two, and if the person, okay, he also left, but it's all right. So with the patient in the left lateral decubitus position, let us like aortic insufficiency, aortic stenosis, mitral insufficiency, mitral stenosis, opening snap, pulmonic insufficiency, pulmonic stenosis, S3, S4, and tricuspid insufficiency. Most likely explanation. What is S4? Alright, so 10-year history. Characteristic finding of S4 heart sound, which it hints at the S4. Also, S4 is a low-pitched sound, making it best heard with the bell of the stethoscope. So, the finding, like the question has that in here, I think it is S4. Also, left lateral decubitus position brings the apex of the heart closer to the chest wall, isn't it? So, enhancing the detection of left-sided heart sounds like S3 and S4. So everything is kind of moving towards S4. Also, chronic poorly controlled hypertension leads to left ventricular hypertrophy, and this results in a stiff, non-compliant left ventricle, isn't it? So when the atrium contracts against this stiff ventricle in late diastole, the S4 sound is produced. That is the mechanism of S4 sound production. And also comparison with other option, that is option H is S3. It is an early diastolic sound, not late diastolic sound as asked by the question. It is also called ventricular gallop, and it is associated with passive filling into a dilated volume overloaded ventricle. Alright. So option D, mitral stenosis, typically presents with an opening snap. So option D and E are not that quite related to in this question. Also, typically the opening is diastolic, not late, but mid diastolic rumbling murmur, and opening snap, it occurs in early diastole again, and in aortic and pulmonary findings, like these are usually best heard at the base of the heart, that is upper sternal borders, and not the apex. So aortic and pulmonic cases are just gone from that one option, isn't it? So, all right. Let's go to option number 8. Question number 8. So in question number 8, in gout, hyperuricemia, that is resulting from overproduction of the urate, is most likely to result from a lack of feedback inhibition by ADP or GDP at which enzyme. What enzyme? So it is asking enzyme from a cycle, isn't it? So it is kind of a boring question from biochemistry, but still, let's just tackle it. So in gout, hyperuricemia resulting from overproduction of urate is most likely to result from a lack of feedback inhibition of ADP. So what inhibits ADP or GDP? At which enzyme? So option A is adenosine deaminase, dihydrofolate reductase, glucose 6-phosphate dehydrogenase, nucleotide phosphorylase, and phosphorybosyl pyrophosphate synthetase. So what do you think? I don't know this one. Let's just check the answer again. I don't know this question. So okay. So it is phosphorybosyl pyrophosphate synthetase. I just want to look at the cycle. What is it actually? All right. So the correct answer is E, obviously. It is commonly abbreviated. So PRPP that we always hear, that is PRPP synthetase. All right. So what is the role of this PRPP synthetase is that this enzyme catalyzes the conversion of ribose 5-phosphate into PRPP, isn't it? And PRPP is a key regulatory substrate for the de novo synthesis of purine nucleotides. So if this if there is a lack of feedback inhibition by ADP in this enzyme, obviously hyperuricemia will happen due to the overproduction of urate, because there is no switch off enzyme thing. So let's just skip this boring question without further explanation. Yeah, I forgot the cycle 2 mother loop, that makes 2 of us. Let's just tackle question number 9. So question number 9 says a female neonate has profound hypotonia. The only known complication of pregnancy was polyhydramnios. Okay, polyhydramnios. So there is maximum amount of amniotic fluid. So mother has a lack of facial expression and weak muscles. She says she did not have any problems as an infant or child. Which of the following best expresses the difference in presentations in the mother? So this question is quite vague. What is it? Option is anticipation, delayed onset, genetic heterogeneity, complete genetic heterogeneity, and incomplete penetrance, and pleiotropy. I can't make sense of this question. A female neonate has profound hypotonia. So, profound hypotonia, mother has lack of expression, facial expression, and weak muscles, and complication was polyhydramnios. So profound hypotonia, it must hint toward floppy baby syndrome and a history of polyhydramnios, often due to poor fetal swallowing. So this is the congenital form of the disease, which is much more severe. The disease is myotonic dystrophy type 1 here. Alright, so it is an autosomal dominant trinucleotide repeat disorder. It is quite a hard question, I think so. And the mother also shows milder symptoms that appear later in life, such as lack of facial expression, facial weakness, and weak muscles, but she was asymptomatic as a child. So the difference, the transition from a mildly affected parent to a severely affected child at birth, is the hallmark of anticipation. What is anticipation? Anticipation is actually a genetic phenomenon where a disease becomes more severe or appears at an earlier age in succeeding generations. That is like genetic phenomenon for diseases like myotonic dystrophy type 1. Alright, so that is all. Delayed onset, there is no delayed onset in here because the patient is neonate. Genetic heterogeneity refers to a single phenotype being caused by different genetic mutations. So let's just move forward from this question. Question number 10. I'll making it a little bit faster now. All right. So an alcohol dependent 40-year-old woman. So your guess is wrong, Madan. It is option A, anticipation. Now, an alcohol-dependent 40-year-old woman who is a healthcare worker has had episodic symptoms of hypoglycemia for the past year. During one of these episodes, plasma glucose concentration is decreased. Plasma insulin concentration is increased. Okay, healthcare worker. So, acute hepatic failure, ingestion of sulfonylurea, pancreatic beta cell neoplasm, retroperitoneal fibrosarcoma, surreptitious use of insulin. Surreptitious is like maximum or more use of insulin. All right, so the patient might be already like diabetic, and he C or he so C, the option is C. So C is already hyperglycemic, and C is using insulin for the treatment. So whenever the blood glucose increases, or whenever the treatment is kind of option, or there is time for treatment, so she might be using that insulin in more concentration than required, because there is decreased glucose concentration and increased insulin concentration. That is an atypical case, and there we cannot see C-peptide concentration either. So it is subserious use of insulin, I think so. So that is all. Question number 11. Double-stranded DNA can be denatured by heating. Yeah, right. You are right. It's E, not B. It's E. All right. So since sulfonylurea is also an anti-diabetic drug, but it does not decrease C-peptide kind of thing. So that is why we have to go to insulin. And double-stranded DNA can be denatured by heating and renatured by cooling. Renaturation or under conditions of high stringency has which of the following effects? Considerable base mismatching is permitted, GC base pairing is inhibited, GT base pairing is promoted, and mismatched DNA hybridization is prevented. The renaturation under conditions of high stringency has which of the following effect? I don't have an idea of this question, so let's just look at the answer key. It says mismatched DNA hybridization is prevented. Okay, so in renaturation under conditions of high stringency has an effect of mismatched DNA hybridization, which is prevented. All right, so let's just jump to the question number 12. All right, here is our clinical question. I just love clinical question more than basic question. All right, so her first child comes to physician's office for a routine visit at 24 weeks gestation. 24 weeks. All right, so the size of her uterus has increased very little during the past 4 weeks. Ultrasonography shows little fluid in the amniotic sac, so it might be a case of oligohydramnios. And which of the following fetal organ systems is most likely to be malfunctioning? So when does oligohydramnios occur? Oligohydramnios occurs if there is deformity in the oligohydramnios, means there is decrease in fluid in the amniotic sac. All right, so how the fluid can be decreased? There is an option of like decreased urination of the fetal of the fetus. There can be due to the decreased urination of the fetus. One option is that. And renal function, I think it is renal function. Yeah, the answer is renal function. All right. Question number 13 is a 35-year-old woman. Okay, I'll bring easy questions, but these are easy questions. It's just that we have not studied very well. These are very easy questions actually. Our study has not reached to the optimum level yet, so I think we need to study better. Nothing. So a 35-year-old woman comes to the physician for an initial visit. She refuses to fill out a questionnaire form about the personal data and her medical history. Then sits silently in the waiting room with her fists clenched. When the physician greets her in the examination room, she says, "Let's get this over with." Which of the following questions is most likely to facilitate communication with the patient? I'm just thinking that we could just video call and discuss the question, Madan, because there is just two of us right here. But I hope that people will watch this. So let's just be direct, all right? Which of the following questions is most likely to facilitate communication with the patient? Are you always such an angry person? This is very rude. We should not use that. I can see that you are upset. Please tell me what is bothering you. Okay, tell me what brings you in. Option number C is quite direct, so we need to develop rapport first. So, should we reschedule your appointment for when you are in a better mood? There is no such thing called better mood of a person. We need to make the mood better. And why are you angry with me? Uh, we should not take it personal, isn't it? So option number E is not even an option. So you do not have to be here if you do not want to. This is very rude. Option B, I think so. I can see that you are upset. Please tell me what is bothering you. Yeah, that is quite humble. I think I'm gonna go with option B, and the right answer is also option B. So question number 14 is an 80-year-old woman comes to the physician because of a 2-week history of mild constipation. Okay, 80-year-old woman, 2-week history of mild constipation, and occasional inability to completely empty the bladder. Okay, there is, okay. So she takes over-the-counter medications frequently. Vital signs are normal. Evaluation shows bladder distension and mild confusion. Which of the following drugs is the most likely cause of her symptoms? So what could it be? Please comment it down. Please brainstorm and comment. I'm just waiting for you because I am also brainstorming for this question right here. Mild constipation. So it must be a pure kind of thing, isn't it? There is constipation. Opioid-induced constipation is very common. And occasional inability to completely empty the bladder. It is a very common feature of old age. So it doesn't have to be that well. And she takes over-the-counter medication. So opiates like diphenhydramine are very usually available in over-the-counter. Also ibuprofen it is available, but ibuprofen does not have a side effect of mild constipation. Evaluation shows bladder distension because of incomplete voiding. And diphenhydramine also has anticholinergic effect, so basically maybe that can happen. Maybe diphenhydramine is the answer. Alright, so let's not think of that as an opioid, because diphenhydramine it is also anticholinergic, and there is decrease in gut motility. There is decrease in gut motility due to diphenhydramine, and that might be leading to constipation. Okay, so the option is diphenhydramine, and it is the right one. Question number 15 is a 27-year-old man is found to have a solitary thyroid nodule during a routine health maintenance examination. Solitary thyroid nodule. A thyroid CT scan shows uptake of radioactive iodine of the nodule. Which of the following is the most likely diagnosis? CT scan shows uptake of radioactive iodine. So there is uptake of radioactive iodine. So what do you think is the answer? Just if you need time, just pause the video and then do it. So chronic autoimmune Hashimoto's thyroiditis, it does not present with solitary nodule. Granulomatous does not present with solitary nodule. Medullary carcinoma, no. Papillary carcinoma, no. The presentation is quite unlikely. So there is also radioactive iodine uptake, so I'm gonna go with follicular adenoma, and that is the right answer. Question number 16, this is quite an interesting one here. So a 32-year-old man with AIDS has a 6-week history of progressive weakness of his right hand, okay, expressive aphasia, and a mild headache. Okay, a CT scan of the head with contrast is shown. Which of the following is the most likely causal organism? Okay, there is progressive weakness in right hand, so the lesion is in the left vein. Expressive aphasia is there, so it might be hitting with Broca's area, Wernicke's area kind of thing, and a mild headache due to the lesion in the brain, of course. A CT scan of the head with contrast is shown here, right here, you can see. The patient has AIDS, man. So there must be some organisms related to AIDS. What can it be? Cryptococcus neoformans, yeah, that can happen, but that is a fungi. Cytomegalovirus does not, it is very uncommon for brain infection. Pneumocystis carinii, it is for respiratory infection. Cryptococcus also is for respiratory infection actually. Toxoplasma gondii, yeah, that can happen. That can lead to this. And option E is Treponema pallidum. It causes syphilis, so the lesion does not quite seem like neurosyphilis. So I don't think treponema is the right answer. Cytomegalovirus, it is very unlikely, Madan. So I think Toxoplasma gondii is the answer. Yeah. So yeah, checking the answer key right here. 16, yeah, D. D is the right answer, Madan. Okay. So let's go to the question number 17. 17 is a 50-year-old woman is evaluated for occult blood in the stool. What do you mean by occult? Do you know what do you mean by occult? Very little. And colonoscopy shows a 5 centimeter sessile mass with a velvety surface that projects about 2 centimeter above the mucosa of the rectosigmoid. There is a polyp in the colon. Okay, 5 centimeter polyp, sessile polyp. Microscopic examination of tissue obtained and biopsy of the mass shows papillae composed of delicate fibrovascular cores covered by dysplastic columnar epithelium. This patient is at increased risk for which of the following colonic neoplasms? So, what do you think? There are papillae. Papillae are common in adenocarcinoma everywhere. You know, these fibrovascular cores and also columnar epithelium. If these features are present, then adenocarcinoma is most likely in almost every areas, in respiratory, also like bronchial and lung adenocarcinoma also. This is very common. So I think it is adenocarcinoma. Carcinoid, fibrosarcoma, leiomyosarcoma, it's very unlikely. Lymphoma, squamous carcinoma, the features does not match at all. So yeah, adenocarcinoma. Yes, Madan, adenocarcinoma. We did it. The right answer is that. Question number 18. We have related to the normal values for parameters that govern capillary exchange. Which of the following is the most likely cause of the edema that results from use of a venous occlusive tourniquet? Okay, so what can happen? Like capillary exchange is mainly governed by hydrostatic pressure and oncotic pressure. Oncotic pressure is managed by proteins, and hydrostatic pressure is managed by, like, it is a intrinsic feature, isn't it? So cause of the edema that results from use of a venous occlusive tourniquet. So if we occlude a vein by tourniquet, what happens? There is like collection of blood proximal to the occlusion of the blood vessel, proximal to the occlusion of the vein, and that will lead to an increased hydrostatic pressure, and that will lead to the leakage of fluid to the interstitial fluid, isn't it? So that means the option is increased mean capillary hydrostatic pressure. Decreased interstitial fluid hydrostatic pressure. Madan Nopani, what are you thinking? How that can happen? decreased interstitial fluid. We don't have to talk about interstitial fluid in here. We are occluding a vein, so there is a collection of blood, fluid proximal to the occlusion of the vein that will lead to increase in hydrostatic pressure inside the vein and thus the leakage of fluid to the interstitial fluid, and that is manifested as interstitial space, and that is manifested as edema. How distal to tourniquet, Madan? If you are like wrapping a tourniquet in the biceps brachii, let's say in the biceps, the blood comes from the heart to the aorta to the subclavian vein, kind of subclavian artery, and then radial artery, brachial artery and radial artery. So alright, let's go to the question number 19. A 72-year-old man comes to the physician because of an 8-month history of feeling lightheaded. Okay, feeling lightheaded when he stands up. Blood pressure is 130 by 85 mmHg while supine and 94 by 64 mmHg while standing. This is a typical case of orthostatic hypotension. So high dose fluid drug cortisone therapy is started. After 5 days of treatment, laboratory studies are most likely to show which of the following changes. So it is asking the side effects of fluid drug cortisone therapy. So answer it. What might be the answer? You can pause the video if you are watching the video after the live stream has ended. So serum and urine, potassium and vanine, what happens? I'm thinking about it too, so let's just take our time. It is a typical case of orthostatic hypotension, obviously. And also this fluid drug cortisone therapy here, it is a synthetic mineralocorticoid, isn't it? So to predict the laboratory changes, we just have to look at the physiological effects of mineralocorticoid receptor activation. So it acts like aldosterone in the DCT and also in the CT of the nephron. Alright. So it binds to the mineralocorticoid receptors, leading to sodium reabsorption. So there is increased activity of epithelial sodium channels, and that will lead to like sodium and water retention. So it helps to expand extracellular fluid volume and treat orthostatic hypotension. This is the reason of using fluid drug cortisone also. And also it causes potassium excretion. So in absence of sodium reabsorption, obviously there is like the potassium must be excreted or secreted into the urine. So this leads to increased urine potassium excretion and decreased serum potassium. So let's just look at the option. Option B seems to be fitting here. There is decrease in serum potassium, but no, there is decrease in urine potassium excretion also. So it must not be B. Maybe C. In C, there is a decrease in potassium, serum potassium, and also increase in urine potassium because there is excretion. Okay, that is the only one that is matching the concept here. And also A also there is matching. So renin, what happens to renin? The renin will be suppressing. We are battling about option A and option C right now. All right. So the resulting volume expansion and increased blood pressure will provide negative feedback, isn't it, to JG apparatus, because there is volume expansion due to reabsorption of sodium along with water. So it will lead to negative feedback mechanism, isn't it? So there will be suppression of renin. So renin will also decrease. So option C might be the right answer. Yes, it is the right answer. Let's go to question number 20 now. I loved this question. I loved this question number 19. It is very logical and it is like it's really well. Question number 20. A sexually active 18-year-old woman comes to the physician's office because of fever, lower abdominal pain, and a purulent vaginal discharge for the last 3 weeks. Tender mass is palpated in the right lower quadrant and bimanual expansion. Right lower quadrant in bimanual examination, which of the following is the most likely site of the mass? So there is fever, lower abdominal pain, and purulent vaginal discharge for the last 3 weeks. Right lower quadrant, there is ovary and fallopian tube in right lower quadrant on bimanual examination. So it must be either ovary or fallopian tube. So it is associated with fever, lower abdominal pain, and purulent vaginal discharge. There is a vaginal discharge, and the infection is not limited or restricted to the abdomen itself. There is discharge, so must be fallopian tube, because ovary, the discharge or the infection of the ovary, the pus formed in ovary will be expanding towards the abdominal cavity, peritoneal cavity, rather than ovary is quite ovary is quite deeply located actually, so we cannot actually palpate ovary in bimanual examination either. We cannot just palpate it. So question number 21. A 13-month-old girl has a history of recurrent bacterial infections, production of superoxide, hydrogen peroxide, and hydroxyl by neutrophils is normal, and production of hypochlorite is decreased following stimulation by opsonized bacteria. The most likely cause is deficiency of what causes HCl formation. Everything is increasing in the cases of superoxide formation, right? So oxygen, reactive oxygen species are increasing except HCl. Why? Why is that happening? Due to which enzyme is that happening? This is a trick question. So catalase, I don't think so. Glutathione peroxidase, myeloperoxidase, and NADPH oxidase, and superoxide dismutase. So in a healthy neutrophil, the enzyme myeloperoxidase uses hydrogen peroxide and chloride ions to create hypochlorous acid. Actually, we need hydrogen peroxide and chloride ions, all right, to form HCl. So in a healthy neutrophil, myeloperoxidase is used for that, because this is an active ingredient in household bleach and also a potent bacterial killer. So maybe this is the option, and the answer key says this is the option 2. So yeah. Question number 22, let's go through that. A 50-year-old man with anginal pain takes nitroglycerin. The pain is rapidly relieved because of this. Just asking the mechanism of action of nitroglycerin, which is cyclic GMP formation. So stimulation of cyclic GMP formation. Option number C is the answer. Let's just pass to the question number 23. Question number 23 says, a 62-year-old man is brought to the physician for evaluation of a 6-month history of progressively strange behavior. He has been impulsive and distractible, has stopped bathing and combing his hair, and has become uncharacteristically rude and unkempt. Occasionally, when eating, he has stuffed food into his mouth with his fingers. He has had some mild problems with memory during this period. Sounds like Alzheimer's already. His only medical problem is a 1 year history of hypertension, well controlled with atenolol. Neurologic examination shows no focal signs, but the grasp and snout reflexes are prominent. Grasp and snout reflexes are prominent. Which of the following is the most likely cause of the patient's condition? Grasp and snout reflexes. These are actually present in Niemann-Pick's disease, so I think it is Pick's disease. Huntington's disease has chorea, normal aging. It doesn't sound like normal aging. Arteriosclerosis is very uncommon. Just because there is a history of hypertension, it is not about arteriosclerosis. Dementia or Alzheimer's type, Alzheimer's type. I think that is a potential option too. So it is either B or E. I'm confused, so I'm looking at the answer key, and it says it's Pick's disease. Okay, it's Pick's disease, alright. Question number 24 says a 4-month-old boy is admitted to the hospital with disseminated candidiasis. He has had several episodes of upper respiratory viral infections and has a history of tetany. 2 months ago, his serum calcium concentration was 2.0 milligram per deciliter. Truncus arteriosus was diagnosed. He was given vitamin D and calcium supplements and was discharged at 1 month of age. Which of the following sets of laboratory findings is most likely at this time? Alright, the question is quite well. There is a case of disseminated candidiasis. So, candidiasis, alright. He has had several episodes of upper respiratory viral infections also, and has a history of tetany. Tetany is because there is decrease in calcium level, alright. So there is disseminated candidiasis and viral infection, tetany and low calcium, that is 2.0, that is 9 to 11 is normal range. It can be due to hypoparathyroidism, and there is also truncus arteriosus, alright. So hypoparathyroidism might be because of the failure of third and fourth pharyngeal process to develop, because it is a 4-month-old boy. And what else is there? Let's just find it out. Okay, this is all, and these symptoms are very characteristics of Diaz-Ortiz syndrome. Diaz-Ortiz syndrome, classic case. It is 22q11.2 deletion syndrome, alright. So what happens in laboratory findings? So the gamma globulins, talking about gamma globulins, these are produced by B cells, alright, so plasma cells. While T cell function is severely impaired, B cell numbers and antibody, that is gamma globulin production, are typically normal in this case. So either B or C is the option. Now talking about peripheral lymphocytes, since the thymus is absent or hypoplastic, because this is the characteristic of Diaz syndrome, just remember that. And T cell maturation is significantly impaired, so but either B or C. Now talking about mediastinal shadow on X-ray films. So mediastinal shadow on X-ray films, there is lack of thymus, and it will lead to a narrowed mediastinal shadow. So the option C, that is 24C, is the correct answer. Alright, option C, 24C, is the correct answer. Now question number 25. The destruction of hydrogen peroxide, which is a mildly toxic reduced oxygen species, is catalyzed by which of the following enzymes? S2O2. It's it is catalyzed by catalase enzyme, obviously. Not a huge thing. Okay, here comes mathematics. The prevalence of breast cancer is compared in 2 groups of women based on parity. The following data are obtained at age 70 in both groups. Breast cancer is equal. So based on this data, what is the relative risk ratio? So the formula for relative risk ratio is the risk in exposed by risk in unexposed. So talking about that, there are 120 women, all right, of total 1500, 120 women of total 1500 who have both breast cancer and children, all right. And then there are 180 people out of 1000 who does not have. Okay, so okay, so 120 by 1500 is the risk ratio for the people, like the women who have children, and it is almost 0.08. And 180 by 1000, it is a risk ratio for the women who do not have children, so it is almost 0.18. So relative risk ratio is 0.08 by 0.18, and calculating it gives 2.25. So relative risk ratio for development of breast cancer in childless women compared with women who have children is 2.25. Option E is the correct answer. Question number 27. We are almost at the end now. A 55-year-old man has had patchy leukoplakia of the anterior floor of his mouth for 4 years. He now has a raised, firm, white lesion in the same area. Examination of tissue obtained and biopsy of this new lesion is most likely to show there is a patchy leukoplakia. He now has a raised, firm, white lesion. Leukoplakia or patchy leukoplakia is a precursor for squamous cell carcinoma. So since there is a raised, firm, white lesion and the patient is 55-year-old and the lesion is for 4 years, examination of tissue is most likely to show squamous cell carcinoma. That is option F. Aphthous ulcer is another name for leukoplakia. Burkitt's lymphoma, it is a different case. Candida infection, it is a fungal infection in immunocompromised patients. It is not the case here. Kaposi sarcoma, it is not the case here. Mixed tumor of parotid gland is not even mentioned here. And Warthin's tumor, it is not Warthin's tumors. It is also like Warthin's tumor is also a case of parotid gland. Not a parotid gland, salivary gland tumor. Question number 28. A 31-year-old, so the answer is squamous cell carcinoma, option is F. A 31-year-old woman is admitted to the hospital in labor at 28 weeks gestation. Administration of which of the following will most likely enhance production of surfactant by fetal type 2 alveolar cells? Corticosteroids. So we all know that. It is a very common question, very basic question. Question 29, a previously healthy 56-year-old man has a sudden onset of severe headaches that become worse in afternoons. His blood pressure is 180 by 110 mmHg. Renal arteriography shows 85% is occlusion of the right renal artery. Laboratory finding that best predicts whether an operation that relieves the obstruction will reduce the blood pressure to normal is increased renin activity in the what? Left renal artery versus right renal artery, left renal vein versus right renal vein, right renal artery versus left renal artery, and right renal vein versus left renal vein. The answer is right renal vein versus left renal vein, option number D. So 30 and last question for today's session is a neonate has ambiguous genitalia. In the first 48 hours of life, the neonate feeds poorly and becomes dehydrated. Which of the following is the most likely diagnosis? Ambiguous genitalia. Neonate feeds poorly and becomes dehydrated. 21. Hydroxylase deficiency is the correct answer, and that wraps up our today's live clinical discussion. And the only person who is here with me until now is Madan Nepani, and thank you for staying here. A lot of appreciation to you. Thank you so much, and we will be now leaving. Alright, please study well and good night to you. Study well and good night to you. Take care. Thank you for staying with me. am now signing off.